Hello and welcome to today's presentation about IDEXX Sdma and its role in pre-anaesthetic screening. My name's Swinney. I'm the Medical Affairs Veterinarian for IDEXX in Australia. Our plan today is to just really briefly cover what Sdma is and its benefits, look at the IRIS guidelines for kidney disease staging briefly, and then look at the role of Sdma in pre-anaesthetic screening, and then finally sort of review what are the implications of increased Sdma on an anaesthetic that you're planning. So most of you are probably familiar with Sdma, symmetric dimethylarginine. It's a methylated form of arginine, is an essential amino acid in the diet, gets used in all nucleated cells and gets methylated. And one of the byproducts of that is Sdma. There's always a turnover of cells in the body, new cells being produced, old cells dying off. And when that happens, when they die off, the Sdma is released into circulation, where it's excreted almost exclusively by glomerular filtration. It's been shown in humans, dogs, cats, and some other species that it correlates well with glomerular filtration rate. And so if the Sdma is increased, it suggests an impaired or reduced glomerular filtration rate, and potentially that reflects reduced renal function. So it would be nice if we could always measure GFR, because that's the primary thing we're trying to assess when we look at kidneys, and we use markers of GFR like urea and creatinine, but it's fiddly and difficult doing it, so that's why we look at other markers. When we look at Sdma, it's a sensitive indicator of kidney function. So, it can increase with as little as a 25% reduction in GFR, reliably at 40% reduction. So it means it's a sensitive indicator. Because of this sensitivity, it's an earlier indicator of a loss of kidney function. If we look at urine concentrating ability, that tends to be gone by about 2/3 loss of kidney function. It's not going to be a sudden we're at normal and then down to nothing with concentrating ability, but it'll gradually reduce, and generally loss of concentrating function at about 2/3, loss of GFR, and urea and creatinine increase roughly around 75% loss. So at 25 to 40%, Sdma will go up sooner. It can be more reliable in creatinine because it's not influenced by some confounding conditions. And probably the most important of that with creatinine is muscle mass. Creatinine is a breakdown product of muscle. So if you've got heavily muscle patients, for example, like a greyhound or an American Staffy, they can have an Sdma that's maybe a creatinine that's a little bit above the reference interval. Animals that have lost a lot of muscle mass, so an old cat with kidney failure, a hypothyroid cat, a dog maybe with hyperadrenocorticism that's lost a lot of muscle mass, the creatinine will drop as a result of that, so it can have less accuracy as a marker of kidney function. We also see Sdma go up as an indicator of concurrent disease. So it'll go up with primary kidney diseases, so chronic kidney disease, acute kidney injury, pyelonephritis, things like that. But it can also go up with, significant cardiac disease, some infectious diseases, some cancers, sepsis, things like that. So it can reflect the effect other diseases are having on the kidneys. It's important to remember that when we look at the incidence of kidney disease, in dogs and cats, the incidence of kidney disease goes up as animals age. So, in dogs over 15 years of age, looking at numbers that they've looked at internally at IDEXX, over 40% of patients will have an increased creatinine or Sdma. But important to note that even sometimes in young animals, we can see increased Sdma and creatinine. That could be from congenital kidney diseases, could be from acquired kidney disease. And the same holds true in cats. In in young cats, you can have potentially 6 or 7% of them, or even more, that can have increased urea and creatinine with that. So even in young animals, we need to be assessing their kidney function as part of a pre-anaesthetic screen. So the question often gets raised, does an increased Sgma always mean kidney disease? And the answer to that question is no, because Sgma can be increased because of renal disease, either acute kidney injury, chronic kidney disease, pyelonephritis, nephrolith or ureterolysis or things like that. But it can also go up with pre-renal disease. If there's reduced perfusion of the kidneys, that's going to reduce GFR, and Sgma can go up. It can go up with post-renal disease as well. So things like, a cat with an obstructed urethra, patients with, ureteral obstructions and things like that, ruptured urinary tracts where there's uroabdomen, Sgma, just like urea and creatinine, will increase in that setting. I'm sure you're all familiar with the IRIS staging scheme for kidney disease. They talk about, the steps to try and diagnose that you've got kidney disease. So history and physical examination findings, and then laboratory tests with that. And then, they have the staging scheme, which involves creatinine and Sgma as the primary markers. This was updated in 2019, so Sgma is now one of the decision makers with staging them. And then the sub-staging based on things like a urine protein creatinine ratio and blood pressure with that. Patients with IRIS stage 1 disease are almost certainly going to be asymptomatic. Even sometimes early stage 2 disease patients may be asymptomatic. So there's always been that challenge of how do we detect kidney disease in these patients. Things we looked at in the past was creatinine increasing within the reference interval? So for example, if you had a dog or a cat that has always run at a creatinine of 100 or 110, if it then goes up to 140, it might still be within the reference interval, but that's telling you that patient's renal function is deteriorating. But unless you're using things like VetConnect Plus, which shows you, you can trend results with that, it was sometimes hard to pick that up. Looking for things like persistent renal proteinuria. If that was persistent or loss of concentrating ability, that could have been an indicator of stage 1 disease. But unless you were doing urine testing for another reason, you weren't going to pick that up. Finally, abnormal kidney imaging. Finding structurally abnormal kidneys on radiographs or ultrasound was also an indicator of potential stage 1 disease. But unless you were doing that abdominal imaging for another reason, you weren't going to pick that up. Now, Sdma allows us to pretty routinely detect patients with IRIS stage 1 disease. We need to demonstrate that it's a persistent increase, just like we would with creatinine, and interpret it in light of physical exam findings, urinalysis findings, looking at the urea and creatinine as well. But because it's a more sensitive marker of the glomerular filtration rate, we can reliably pick up early stage kidney disease sooner. So I have a question for you, and it's always difficult in a presentation without a live audience, but would you consider doing a pre-anaesthetic screen without a creatinine? And I think most of you would say no. That if you're going to do a pre-anaesthetic screen, which we would encourage, that you would include a creatinine in it. So I'd raise the question of, if you're going to do a creatinine with it, why not add an Sdma as well? Because it's going to potentially help us pick up patients with earlier stages of kidney disease. And if we detect a patient with IRIS stage 1 disease, it gives us the opportunity, first of all, to look for a cause of it, to see can we find out, is there something active happening that's contributing, to that loss of glomerular filtration rate. But even if we can't find that, we can take steps to try and slow the progression of disease over time. The question sometimes comes up. I think it's often easier if you've got a patient that's got clinical signs, is azotemic, is isostonuric, and it's got a high Sdma. We all know what to do with those patients. You stage them and manage them as a kidney disease patient. But sometimes those patients that have got they're normal clinically, their creatinine's normal, but you get a mildly increased Sdma. The question is this significant or not? Does it mean they have early stage kidney disease? Could it just be that they're dehydrated? Is it going to go back to normal? And that, raises questions with it. You can find things. We've got an IDEXX Sgma algorithm that gives guidance on what to do in a patient with a mildly increased Sgma. For me, if you've got that 15 to 19 increase in Sgma, if it's normal is less than 14. If it's say 15 to 19, which is a mild increase, your creatinine's normal, your urea's normal, the patient is clinically normal. At a minimum, it's good to collect a urine sample from them. Is there any signs of active disease in the urine? What's their concentrating ability? If you have clinical signs or the creatinine's up, obviously we're going to do a more thorough investigation of looking for a cause and seeing if we can find something. But if everything else is normal, as I say, at a minimum, at least check urine. The question then comes up of what are the implications of a mildly increased Sdma if you're doing this pre-anaesthetic screen on the procedure that you're planning. As we discussed before, that increased Sgma could be pre-renal or renal in nature. So guess what? If it's pre-renal, just rehydrating them and getting them on some fluids is probably going to be enough to, make sure that the procedure is without event. And then we have the question, is possible iris stage 1 disease a preclusion to anaesthesia? And I'm saying possible iris stage 1 here disease because, if this is the first time we've demonstrated the Sgma is increased, to confirm it's stage 1, we need to show it's persistent. But, this mildly increased Sgma is not in any way, shape or form a preclusion to anaesthesia, if they're otherwise well. Considerations would include, do we make sure that they're on some intravenous fluids during the procedure? If it's pre-renal, that corrects it. If it's renal, it helps protect their kidneys. Monitor their blood pressure during the anaesthetic to make sure it doesn't get low. Analgesia choices, maybe we would lean towards an opioid rather than a non-steroidal in that setting. And we know that if we've had that mild increase in Sgma, we should follow that up down the track. And other things, pre-oxygenating a patient if they need oxygen after, but just that fluid support, monitoring blood pressure, and being careful with analgesia, careful with the choices is important, and means that in a lot of cases we can go ahead and undertake the anaesthetic. There's always also that question of, if you've got a mild increased Sgma, say in that 15 to 19 range, what are the chances that that carries significance and is going to be persistent? So IDEXX had a look at that. They reviewed large numbers of patient records, and they identified patients that had bloods processed where their creatinine and Sgma were normal. Then the next time they were measured, the creatinine, they looked at what the creatinine was, but they had to have a mildly increased Sdma in that 15 to 19 range. So there were around about 16,500 dogs and cats each that met those criteria. And then these patients had to have another sample within 12 months to see whether the Sdma was persistent or not. When they looked at the numbers with this, 48% of the patients that had that mildly increased Sdma, it was persistent. So when another sample was done within that 12-month period, the Sdma was still elevated. 52% of them, the Sdma went back to normal, suggesting that the glomerular filtration rate increased back to a normal level. But when they followed some of these patients out, of the 52% of patients that had a restoration of normal GFR with a normal Sdma, within 12 months, 24% the Sdma went up again. So when we put those together, the chances that an Sgma is going to be persistently increased, 12 months after a mild increase initially, is 72%. So I think when you look at numbers like that, it tells us that there is significance in that mildly increased Sdma. It's great if it goes back to normal and that patient's glomerular filtration rate normalizes, but there is a 72% chance, looking at this significant amount of data, that it's going to stay persistently increased, suggesting that we likely have an IRIS stage 1 patient. Interestingly, when they looked at this at the time with where the Sgma was initially mildly increased, only 19% of the patients had an increased creatinine at that stage. By 12 months, only 48% of them had an increased creatinine. But as time went out, that number increased. So it shows us that the Sdma increase is likely going to come before the creatinine increase, which is not surprising given the degree of reduction in the glomerular filtration rate we need to cause them to be increased. So even if the creatinine's normal, don't discount that Sdma being elevated. So in summary, I think we know that Sdma is a valuable parameter when we're trying to assess glomerular filtration rate. And because it increases with less reduction in GFR, it allows us to pick up IRIS stage 1 disease. We can look for a cause which can drive further diagnostics, and we can take steps to try and slow progression of disease. And that 72% chance that a mild elevation in Sdma will persist. So I think Sgma does have a place in a pre-anaesthetic screen to identify those patients that maybe we just need to take some extra steps with their anaesthetic to try and protect their kidneys, but it is not in a patient that's otherwise healthy. It is not necessarily a preclusion to that anaesthetic being done. If you have any questions, please don't hesitate to reach out to one of us at IDEXX through your local DPC, or reach out to me, and we're happy to answer your questions. Thanks for your time today, and we'll see you at another education session soon. Thanks very much.